Good afternoon, everybody. Sorry for the slightly late start. One of our speakers is on his way, and we understand very nearby, so we'll be here shortly. So, welcome to Center for Policy Research. I think many of you were here for the first in this series. As you know, we are holding a series of talks over the next few months, trying to have a talk every couple of weeks. And this series is titled Clearing the Air, with a question mark after it, a seminar series on Delhi's air pollution. Last week we had Dr. Sharat Kutikunda, who took us through some of the data on emissions, how we know about different emission levels and so on and so forth, as well as the pitfalls with tracking emissions. And this week, as well as the next talk, will focus on the health effects. Of air quality in Delhi and the surrounding regions. So we are really very pleased that in order to put together this talk, we have with us colleagues from the Public Health Foundation of India, who is co-sponsoring this discussion, and we're really pleased to welcome them here. They're all experts in this area of health effects of air pollution. And I'm just going to very briefly introduce the colleagues we have with us, and then hand it over to them for the actual conversation. So first, Dr. Prabhakaran is actually not here yet, but will be joining us shortly. So let me just tell you a little bit about him as well. So Dr. Prabhakaran is a cardiologist and epidemiologist by training. So he's the Vice President for Research and Policy at PHFI, and is also the Executive Director of the Center for Chronic Disease Control, New Delhi, and a professor at the London School of Hygiene and Tropical Medicine. Dr. Prabhakaran works on a series of a whole range of issues having to do with cardiovascular diseases and their links to air pollution and other sort of related questions. We were due to have with us Dr. Raj Kumar to talk about pulmonary issues, but unfortunately he had to pull out at the last minute because he has some obligations with the government, and we'll try and in future talks maybe invite somebody who can speak to those issues more directly. We do have with us Dr. Preet Dhillon, who has a background in cancer epidemiology. I'm going to have to get used to saying that word fast, clearly for this series. And Preet is a senior research scientist and associate professor at PHFI Center for Chronic Conditions and Injuries and the Center for Environmental Health. And then we have with us Bhargav Krishna, who's going to kick this discussion off and also sort of moderate the discussion a little bit, who manages the Center for Environmental Health at PHFI and leads the engagement with the government, corporate sector, multilateral and bilateral agencies. Dr. Prabhakaran, welcome. We just did a round of introductions. As I said, we're really delighted to be hosting this in collaboration with PHFI. As we have done in our first seminar of this series, we're going to be video recording this discussion. The videotape will be up on the website. We also will have a short question and answer format up on the website. And so please do spread the word for those who aren't able to be here. Maybe they can access our website in about 3 or 4 days and take a look at the video and other materials. So as always, the format for this is quite informal. We'll hand it over now to our colleagues at PHFI, starting with Bhargav. They'll talk for maybe about 40-45 minutes, and we'll have a chance for question and answer. Thank you again very much for coming. So over to you, Bhargav.
Thank you very much, Navros. Good afternoon, everybody. It's a pleasure to be here and speak to all of you about a subject that we are very concerned about on a seasonal basis annually, air pollution and health. So what we'll do today in terms of the structure is I'll speak to you a little bit about to set the context of what air pollution and health is looking like in India. Dr. Prabhakaran will speak a little bit more specifically about the links with cardiovascular disease, some of which we are doing at PHFI as well. And Preet will try and cover aspects of respiratory illnesses as well as cancers and their link to air pollution. And then we'd like to have a fair bit of time for discussion at the end of that. So I'll just jump straight in. Ambient PM 2.5, which is the measure that we look at for air pollution exposure outdoors. If we look at growth of ambient PM 2.5 over time between 1998 and 2014, we can see that the vast swathe of the Indo-Gangetic plain has been experiencing a growth in ambient PM 2.5 exposures. Over 99% of the districts in the country are above WHO safe guidelines for exposure, which is 10 micrograms per meter cubed on an annual basis. And over 60% are above the national ambient air quality standards as well. So those are standards which are far more lenient compared to the WHO standards. And yet we are unable to meet those targets, those more lenient targets that we've set for ourselves. And if we look at over time, the problem only seems to be growing. Air pollution or ambient PM pollution has a seasonal aspect to it. So this is a picture that was taken by a friend of a friend in Gurgaon. And you can see the vast difference. This was last year. The first picture on the left is a day in August after the monsoon, and the picture on the right is the day after Diwali. And you can see the sort of vast difference that you experience in Delhi, within one narrow space of the geography of India in terms of air pollution exposure. So there is a big seasonal component to air pollution exposure as well. But it's also a regional challenge. I mean, the first slide as well showed the fact that air pollution is not a Delhi only issue. I mean, we talk about it a lot in the context of Delhi and the impacts that are being felt by people in Delhi and the lack of policy action that is taken in Delhi. But the challenge is much broader than Delhi. So Delhi air pollution is not going to be solved just by addressing issues that are local, as we've seen with the debate on stubble burning. But it's also the fact that there are places outside Delhi which are experiencing far higher levels of air pollution on an annual basis. We've just completed some analysis ourselves, which we'll be publishing over the next month or so. For 2015 and 16, Delhi is not even in the top 3 of the most polluted cities in the country, even though we hear a lot about it. So places in central India, for instance, are far worse, and they have far lower levels of monitoring. I mean, the number of monitors in Delhi is only growing. The CPCB recently announced that it's increasing the number of monitors from about 21 to about 48. Yet we have places like Korba, or we have places like Raipur, or we have places like Ranchi, where we don't even have a single monitor in many cases. And these are places which experience far higher levels of air pollution. Another dimension which doesn't really get spoken about in the air pollution debate is the household air pollution issue. A huge chunk of the Indian population continues to use solid fuels such as wood or coal or dung as a source for cooking or heating. And this produces essentially Diwali levels of exposures on a daily basis within approximately 300 million households in the country. If we look at the data, rural India, as per NFHS4, it is still a very small sliver of the population. So this survey was conducted just prior to the Ujjwala Yojana, which aims to provide LPG connections to 50 million people by 2019. But we see the challenge is vast. I mean, we're talking about increasing supply of LPG in rural areas from a proportion of about 24% to the entire population. It's going to take a long period of time. And in many parts of the country, household air pollution is a huge contributor to outdoor air pollution as well. So in Delhi, probably biomass burning is a small proportion. In many tier 2, tier 3 cities, it could be about 20%. In rural areas, it's about 50%. So it is an area that we need to tackle when we're thinking about ambient air pollution as well. So what does this mean in terms of the burden of disease? If we look at the 2015 global burden of disease, we see that air pollution was the number 2 risk factor for mortality in India, resulting in about 1.8 million deaths. We presume, of course, that a large proportion of these deaths are via respiratory illnesses, but we'll actually see that this entire big block here is cardiovascular diseases. So ischemic heart disease or stroke were the 2 endpoints that were considered for these. Of course, Dr. Prabhakaran will speak a lot more about this in detail, but I just wanted to bring it to the attention of everybody here that we talk about asthma attacks, we talk about shortness of breath, but it's not just that. It's also a risk factor for heart attacks. It's also the number 1 risk factor for DALYs, which is a measure of lost productivity as well. Globally, if we look at the deaths attributable to ambient air pollution, we see that India and China are leading the pack. This is percentage of deaths attributable to air pollution across different countries. So India and China are about 8 or 9% of all deaths are attributable to air pollution. But the worrying aspect here is that while China has taken a number of actions over the last 3 to 4 years to address this issue, projections show that between 2010 and 2050, this problem is only likely to grow in India, whereas it's reducing in many other parts of the country. And if we look at the area that is going to grow, it's once again the same geographical region, which is the Indo-Gangetic Plain. some work that was done by our colleagues at PHFI along with the Indian Council of Medical Research and Institute of Health Metrics and Evaluation, trying to understand what the burden was at a state level, also showed the same picture, which is that DALIs attributed to air pollution are really distributed quite heavily amongst the states of the Indo-Gangetic Plain. Bear in mind, this is model data, and there will be some challenges with providing really strong estimates to some of these issues, especially because the quality of air pollution data that is collected is really not very good by our Indian government, especially in, like I mentioned, parts of central India where the levels are probably going to be a lot higher than what we experienced, but the overall picture won't change as much. What we've also seen in the last sort of 2 decades is that air pollution, while we've seen other health outcomes that are linked to developmental issues that are traditionally seen in low and middle income countries like child and maternal malnutrition, issues like infectious diseases have come down considerably, while air pollution has gone up. So it's gone up from being the number 3 to number 1 risk factor for dialysis across both sexes in this period. So what I'll do now is I'll break and I'll hand it over to my colleagues to talk a little bit more about the other issues in depth. Oh, it's already open.
Yeah, okay. So thank you, Bhargav, and good evening to everyone. Apologies for being a little delayed. The Gurgaon traffic is unpredictable, but another unpredictable thing happened to me, so I got delayed further. So what I'm going to do in the next 10 minutes or 15 minutes is persuade you to agree to the fact that air pollution actually impacts cardiovascular disease substantially, because a lot of us think that it causes respiratory illness, it causes asthma, it increases chronic obstructive lung disease and so on. But many of us really do not know that it really impacts cardiovascular diseases. So air pollution impacts cardiovascular diseases through multiple mechanisms. First, it increases the risk for hypertension. Second, increases the risk for diabetes. Third, it increases the risk for heart attack. Fourth, the stroke. Fifth, peripheral vascular disease. And also it has some effects on the regularity of the heartbeat. It can result in what we call as cardiac and even sudden death. Briefly on cardiovascular disease in India, we all know about this fact. There's a huge burden of cardiovascular disease in India. These are figures which are comparing the global averages, and as you can see, for all types of cardiovascular disease except cerebrovascular disease, India has a very high level of mortality due to cardiovascular disease, be it ischemic heart disease, which includes heart attacks, rheumatic heart disease, hypertensive heart disease, and ultimately total cardiovascular disease. Just to give perspective on the risk factors, hypertension, which is one of the most important risk factors for cardiovascular disease, actually causes the major chunk of the problem. And the size of the bubble gives you the size of the problem. So hypertension, which is the most important risk factor for cardiovascular disease, is one of the leading cause of death worldwide. Now, one might say, okay, this will pass off, but the projections are really, really worrying for us. In terms of hypertension, in the year 2000 or even currently, we have around 140 million people with hypertension. By the year 2030, it will increase to 214 million. Now, you might be wondering, why are there these 4 figures for diabetes, 30, 61, 67, 69, and so on? In the year 2000, we had 30 million people with diabetes. And that year, the International Diabetes Federation predicted that by the year 2025, we will have 65 million people with diabetes. Now, you can see we have achieved that figure 10 years or 11 years earlier. So, every year it keeps changing. So, current estimates are that there are 70 million people with diabetes. It's likely to increase to 124 million, and there are figures by 2040 it will go up to around 150 million. In terms of tobacco, nearly 1 million people die of tobacco. By the year 2030, 2 million people will die of tobacco. Cardiovascular disease also will increase, 2.7 million deaths or 3 million deaths currently will increase to 4 million. And cancer is one of the problems which is rapidly increasing, and you can see from 0.73 million it will go up to 1.5 million, almost double. In terms of air pollution, one might ask, what is the excess risk induced by air pollution? There are lots of problems in this kind of analysis, but one thing that we can see is that there is an increase of 5 to 10% extra risk because of air pollution. So, for example, if a person is a smoker, smoking increases the risk 3 times, which is really high risk. Diabetes increases 3 times. Air pollution would increase around 10 to 20%. But the big problem arises when people have coronary artery disease, people have heart failure, people are smokers, or people have other risk factors. It can actually compound that, and it can increase it substantially. So this is in terms of numbers which Bhargav alluded to. 832,000 cardiovascular deaths occurred due to air pollution in the year 2015, and around 1.8 millions we can attribute to non-communicable diseases. Now, Delhi is one of the measures that we do. So, in terms of metrics of measurement of adverse outcomes, there are 2 ways of doing it. One is to look at deaths, and the second is to look at premature deaths. Like, for example, if the life expectancy is 66 years or 70 years, let's say, and a person dies at, say, 40 years, the number of years lives lost is 30 years. The number of, suppose the person has a heart attack at 40 years, lives till, say, 50 years, you also have years of life lived with disability. A combined matrix is called daily, and that's a useful measurement to see what is the impact of many of these factors, and in terms of daily loss, it's quite high. Now, one might wonder, how does this happen really? I mean, we can easily explain, respiratory diseases, the pollution gets into the lung and activates a cascade of reaction, but how do we explain this cardiovascular disease occurrence? The first is that PM2.5 is a very, very small particle. I mean, it's a series of a number of things, but they're all minute. Because they're so minute, they can cross what we call as the alveolar lung barrier. In the lungs, you have alveolus where gas exchange takes place, so they cross that barrier, get into the blood. Once they get into the blood, they damage the endothelium, which is the lining of cells on the blood vessels. And once that is damaged, a cascade of effect occurs. So it increases inflammation, it increases the risk of clot formation, and ultimately clot is formed, and that can result in heart attack. The second thing, what happens is what we call as endocrine disruption. So inflammation, particularly in the fatty cells of the body, where fat cells are deposited in and around the abdomen, they are influenced by the paracrine effects of the liver and other organs, and they become very active. Once they become active, they increase the risk of what we call as metabolic abnormalities, such as hypertension, diabetes, and so on. So all of these ultimately would result in heart attack, stroke, peripheral vascular disease, and arrhythmias and sudden death, as I had said. The last point that I wanted to make is that Bhargav made this point that a lot of us think about lung disease. Most of us, when you think of pollution, we think that acute lung infections in children, acute respiratory infections in children are heightened by pollution. If you look at the population attributable risk, which means how much of the risk in the population can be explained by this risk factor, it's very similar. Whether it is lung infection, whether it is ischemic heart disease, or whatever, it is very similar. But the focus on cardiovascular disease is not there. One of the reasons is that these are all model data. There's very few data that is available. Most of it is modeled on small amounts of data, and then they give this figure. So people think that it's not credible. And that's where we actually come in. And this is a few years back, the government of India asked PHFI along with IIT Delhi to publish a document on air pollution. And a lot of literature was reviewed, and one of the suggestions was that evidence for policy development was there, but it needs strengthening from Indian evidence. So what is the current evidence base in India? Most of the studies in terms of air pollution is exposure assessment. When you study air pollution, you want to look at 2 things, exposure and outcome. the great strength in Indian studies lies in exposure assessment, but it's kind of weak in terms of outcome assessment. Most studies haven't looked at PM 2.5, they've looked at other particles. There is little or no examination of cardiometabolic diseases, outcomes and risk factors, early life influences, and neurodevelopmental effects. The other thing is the design effect. The problem is when air pollution is being studied, people relate air pollution to the presence of a disease at that given time. Now, these are not temporarily related. It may be by chance that they could be together, or there may be other reasons why they are together. So, you need to look at them longitudinally. And then, microenvironment profile is not studied adequately, and therefore, we applied to NIH along with Harvard as our partner, and we plan to establish a fully integrated research and training program on air pollution and cardiometabolic diseases with policy relevance to improve health of Indians. So in terms of research, we propose to advance science of ambient air pollution epidemiology on cardiometabolic diseases, risk factors and outcomes, evidence and knowledge to inform development of policy on transportation, energy and urban planning. But there is also a huge component of training and capacity building, because we need that kind of capacity building for understanding air pollution, for addressing issues related to air pollution, for policy development and so on. So opportunistically, we had established this cohort. Cohorts are required to study longitudinally the effects of disease. So we established a cohort in Delhi, Chennai and Karachi, but for this study we are looking at Delhi and Chennai, where we established a representative cohort of more than 12,000 adults and recruited them between the years 2010 to 2011. We have an annual questionnaire follow-up and collect biological samples every alternate year. The participants are fully phenotyped for cardiometabolic diseases, and importantly, the households are geocoded and integrated into a GIS database, and cardiometabolic events and risk factor data are collected every year, and every alternate year we collect biological samples so that we can get incidence of disease. And we have long-term biorepositories and storage of biosamples, and these can be extremely useful in terms of looking at biomarkers. The other thing is, along with several partners that include urban emissions, IIT Delhi, IIT Bombay, IIT Kanpur, CSIR, St. John's Medical College and so on, we have developed an air pollution model in terms of developing, in terms of developing in terms of estimating PM 2.5. So the first aim was actually to link the level of PM 2.5 to the incident cardiovascular disease. The second was to estimate association between exposure to air pollution, temperature, cardiometabolic risk factors and cardiometabolic diseases and characterize their susceptibility. Identify susceptible population based on socioeconomic status, occupation and built environment. Then in terms of built environment itself, we are looking at neighborhood walkability, traffic density, availability of parks, green spaces, healthcare access and so on. And then to investigate whether socioeconomic status, occupation or built environment modify the effect of air pollution through differential exposures and susceptibility to pollution related effects. And so we use complex mathematical modeling to understand this. The second most important thing that we are doing is use a nested case control design. That means all the cases that occur, all the incident cardiovascular disease that occur matched and to normal controls, and we look at whether there has been an epigenetic modification because of pollution. And the last one is, like, for example, when you look at it today, there's no exposure to the sun, and it is said that most Indians, despite having huge amounts of sunlight, are vitamin D deficient. Either we do not go and walk because of the heat in the summer when the sunlight is widely available, or in the winter there's no sun. So we want to show that this vitamin D deficiency, which is so widely rampant in India, is related to air pollution. And the last thing is to look at personal exposures, because that's never been done. So one of the things which you want to look at is personal exposures and see how overall air pollution and personal exposure are related, and how they are related to disease outcomes. So to conclude, cardiovascular disease causes major death and disability in India. there's actually been a huge amount of increase in terms of cardiovascular disease in the last 50 years. In the 1970s, people didn't even think about cardiovascular diseases, and in fact, worldwide, in WHO there was no department to look at cardiovascular disease, and in fact, India was the first one to request. I don't know why they did that at that time, but they requested. The putative mechanism linking air pollution to cardiovascular disease is known from small studies, and we think air pollution could be a major contributor for the rapid escalating problem of cardiovascular diseases, and that's what we are trying to prove by our studies that we are conducting. Thank you.
Thank you, Dr. Prabhakaran. I'll now hand over to Preet to talk about the cancer-related aspects of air pollution as well.
Okay, great. So I am going to give an overview in the next 15 minutes or so with respect to the evidence in terms of what we know about air pollution and cancer. So I'll give a little bit of an overview in terms of the global burden of disease, and then talk about the WHO classification of carcinogens and how air pollution fits into that. And then talk a bit about what are the mechanisms of carcinogenesis for air pollution, and then go into the evidence. And I'll try to highlight in the evidence, the global evidence, to what extent the data are coming from low and middle income country settings like India, and then finish off with what I think are some of the gaps and areas that we can work on for this particular area of interest. So if we look globally, the people talk about the lifetime risk of cancer, and there's over 17 million cases of cancer globally and close to 9 million deaths. The rate of cancer has been increasing worldwide. A large percent of it is due to population aging and population growth, but there are changes as well in risk factors and lifestyle patterns that are attributing to that. Up here I've written what are the leading sites, and TBL stands for tracheus and bronchus lung carcinoma, so that's lung cancer. So you can see that for both men and women, lung cancer ranks amongst the most common cancers. And if you were to look here by region of the world and the specific types of cancers, because people say cancer, but it's actually not fair because there's over 30 different sites of cancer, and each one can have different mechanisms of carcinogenesis. So there are some common ones, but if you look across different regions of the world, it's pretty stark that lung cancer is the most common, including our region of the world. So if we move to the WHO and its classifications, you have the International Agency for Research on Cancer. They try to summarize all the evidence and put out reports in terms of what's considered to be a carcinogen or not. They have to look at all the evidence. So they have to look at mechanistic evidence, evidence in animals, evidence in human beings, and then try to judge this evidence in terms of its quality, in terms of the study design. How are they longitudinal studies? Are they just correlational studies like cross-sectional studies? Do we see dose-response effects where you have, higher effects with higher durations and doses? Is it biologically plausible, etc.? So they bring all that data together, and it takes quite a bit in order for them to classify something as a group 1 carcinogen. In fact, they have various categories you can see there that go from group 1, which is definitely carcinogenic in the opinion of WHO, down to probably, possibly, and down to probably not carcinogenic. So if you look here at the list of group 1 carcinogens by the WHO, so this is the International Agency for Research on Cancer, I've highlighted those that are related, most of these, to air pollution. So outdoor air pollution, most recently in 2013, was declared to be a group 1 carcinogen by WHO. Prior to that, we already had engine exhaust, diesel exhaust, indoor emissions from household combustion, and then some of these other components like benzene, benzopyrene. These are compounds that are part of air pollution as well. So we already have the evidence in terms of air pollution and cancer. However, like I said, cancer is many different diseases. So most of that evidence actually is consistent because we have some of these compounds. So those particular compounds, such as benzene, diesel exhaust, benzopyrene, as I noted on the previous slide, these are group 1 carcinogens. They're also in air pollution. So a lot of the times when you have studies on air pollution, if they can't measure PM 2.5, some of the monitoring stations might have these kind of data. So these get used as surrogates for air pollution. I'm mentioning that now because as I review the evidence, you'll see that different studies will focus on different measures of air pollution, and it really depends on the location. And then the evidence is basically consistent for lung cancer. So while it's a carcinogen more broadly, it's basically because of the evidence around lung cancer. Now there's 30 plus other sites of cancer, and people may be curious about those, like breast cancer or colon cancer, oral cancer. So there the evidence is not as strong, and I will show you that. But basically, the lung cancer evidence in animals, humans, mechanisms, it's very consistent, it's strong. However, I just want to note that the majority of those studies were done in Europe and the US, and according to the WHO, virtually all of those studies had annual average PM 2.5 levels between 10 and 30. So you can consider that in what we're facing today and the context of countries like ours. So these are the most frequently measured pollutants when different studies around the world try to look at air pollution and cancer. They will take one or more of these pollutants and try to look at the association. And then, of course, studying air pollution with respect to cancer or any other health outcome is even more complicated by the fact that you have these various mixtures, and it gets difficult to try to capture all of that with respect to a health outcome. And how does it work? So basically, you've got incomplete combustion, and it results in these various compounds: polycyclic aromatic hydrocarbons, volatile organic compounds, or metals and other metal compounds. And I will use acronyms for these in the following slides because it's a mouthful. And basically, these inhalable particles, like Dr. Prabhakaran said, they can cross the barrier, and once they get past the alveolar regions, they get metabolized. And the byproducts of that metabolism can attach itself to different parts of the DNA, for example, and you can get these DNA adducts. That can cause the expression of genes to be turned on or off, as an example, and those genes may be oncogenes, for example, that may promote carcinogenesis, or they could be tumor suppressor genes that get downregulated, and those are the kinds of genes that make sure that the cell cycle is continuing to do everything it's supposed to do. And so that's one mechanism by which you have these various components of air pollution leading to carcinogenesis. As Dr. Prabhakaran mentioned, with respiratory and cardiovascular, similarly with cancer, you can get a cascade of events. And this cascade of events leads to tumor formation. It can happen through inflammation. It can happen through cell injury or proliferation, a depletion of antioxidants, and basically different mechanisms of the cell repair, proliferation, cell death cycles get impaired. And as a result, you can have the carcinogenous pathway begin. One of the very tricky things in studying cancer for any particular exposure that you're interested in is that you have typically very long latency periods. So typically it's up to 10 years. So when people talk about, studying air pollution and cancer, you can't study the levels today and look at cancer outcomes today. You can, but it's a correlation, and definitely whatever you're observing now is not related to cancer now. The assumption would be that if you're in one place for the past 10 years and the levels have been sort of stable, that whatever you were exposed to over the past 10 years and more importantly in the distant past, that would be related to your risk of getting cancer. So that's another thing that makes studying cancer particularly challenging and methodologically challenging when you have to look at the evidence and summarize it. So these are the various types of study designs that are done with respect to looking at cancer. People try to follow longitudinally people over time. Ideally, you'd want the health outcomes on each person, and you'd want each individual's actual air pollution exposure. That's ideal and doesn't happen for outcomes like cancer. It can happen for more common outcomes. But for cancer, the rates of cancer, so for in India, the incidence rate of cancer is approximately 110 per 100,000. So for every 100,000 healthy people in a year, around 110 will develop cancer. So if you want to try to look longitudinally over time and capture, does such and such cause cancer, you need something like at least 20 to 50,000 people followed for at least 5 to 10 years for you to get enough cancers. And that's an overall cancer, right? And you wouldn't look at overall cancer, you would look at lung cancer or nasopharyngeal cancer or oral cancer. So your numbers would need to be much larger. Just emphasizing the challenges of trying to do this kind of work and also why so little of it comes from settings like ours. And most of the data really come from high-income settings. And then, as I mentioned, there's different ways that we think about exposure. And in general, when you're looking at the evidence, you want to see, does the association get stronger with higher levels, for example, and do you see differences depending on where you are? This is sort of a snapshot of the various parts of the world where this kind of work has been done on air pollution and cancer. And those are the different sites of cancer in general that have been done. This is an overview. I probably missed a few out there, but it gives you a sense of what people are looking at and what is the evidence out there. So there have only been a couple of reviews, and this is where people try to collect all the individual studies together to try to make more sense and get more statistical power out of bringing the evidence together. Most of it's focused on leukemias, actually, childhood leukemias. And out of those 2 reviews that were done focused on leukemias, there were only 2 studies out of 26 that were done in low and middle income countries, and those were in Taiwan. If you looked at breast cancer and nitrogen dioxide, 1 was in Saudi Arabia, and then the rest are in Europe, North America countries. So just keep that in mind in general as we go through the evidence. Not to say that we don't have risks here. In fact, I'd be more concerned here, which is why we need to do this kind of work. So after the reviews, the next strongest kind of evidence we have is when we can longitudinally follow people repeatedly over a period of time, like those huge numbers I was talking about, 20 to 50,000 for at least 5-10 years. These are the studies. There's been about 10 of these so far that have looked at different types of cancer outcomes. The one is the cancer prevention study. Look at the numbers that I'm talking about. 623,000 people followed for over 20 years. And then you have great systems where you can just pick up this death certificate data and link the information. You've got monitoring stations that have the data on various criteria pollutants, and so you can try to associate it at the individual level. Kidney cancer, bladder cancer have been looked at, and they've been shown to have a 14% increase for just that level of increase, 4.4 micrograms per cubic milliliter of PM 2.5. Something similar for bladder, half of that for colon. That's for nitrogen dioxide when we look at parts per billion. So I can see some of you just sort of shaking your heads, because if you look at these percentages and what those incremental increases are in PM 2.5, it's shocking if you have to think about it in the context of where we are here. The Adventist Health and Smog Study, it's famous because it's the Seventh-day Adventists, and they're all non-smokers. So a lot of the evidence on lung cancer also has come from non-smokers, and the associations in some of these studies are even stronger in women and in non-smokers. So the evidence is just as strong, if not stronger, for air pollution and lung cancer, even in non-smokers. That's why I put that one up there. In general, the evidence that I'm going to review is not for lung cancer, though. In the Danish nurse cohort, they looked at brain cancer, but they didn't find an association. Something called the sister study cohort, close to 50,000 women in the U.S., they did not find an association with breast cancer and air pollution, but they did find a 10% increased risk in hormone receptor positive cases with respect to nitrogen dioxide. Like I said, each one of them was able to look at individual pollutants because they have that information coming from the monitoring stations. And then the California teacher study, again, over 100,000 teachers followed for over 15 years. But again, they were not able to find an association with breast cancer. Here's a study that was done in Europe, in Denmark, Austria, and Italy. Again, close to 175,000 people, 4 different cohorts over 17 years. They did not find an association with liver cancer. The California Cancer Registry, they wanted to look at liver cancer patient survival. And actually, they did find an association for each 5 microgram per cubic meter of PM 2.5. Not for the distant stages is as much. And then a similar study looking at lung cancer survival. And then this is the kind of data that we would be doing here in India, is where you would just do individual case control studies, right? You would go and you would partner with a hospital and you would collect cases, either coming from a cancer registry or a particular hospital, and then you would select controls to be comparable to the cases in aspects other than your particular exposure of interest. You don't want to overmatch. And so a lot of these types of studies have been done in different parts of the world. Again, majority are in high-income countries. So for example, a study looking at nitrogen dioxide and ultrafine particles. So now this is PM1. In Montreal, didn't find any association. And then, again, looking at childhood leukemias in the U.S., adult leukemias in Canada, and no significant associations. Breast cancer in New York, retinoblastomas in the U.S., and there they did find that there was an increased risk. Prostate cancer, bladder cancer, no significant association. And then in Taiwan, they looked at bladder cancer mortality, and again, they did find significant associations. A 37% increase in risk. Where you see that percent, it's an increase, or a 90% increase in risk, 98% increase in risk for nitrogen dioxide and sulfur dioxide. And then you have ecological data, where you try to look at spatially differences in air pollution and spatially differences in rates and try to make correlations. And so that kind of work has been done as well. A couple of those studies have been done in Taiwan. So they looked at bladder and ovarian cancer, and they did find significant associations. And then these are some of the other studies. I just want to bring, just to kind of wrap it all up, we have, unfortunately, a lot of the exposure and health outcome data are missing in low and middle income countries. We're often missing the important confounders. So especially with ecological studies, but even when people do some of these studies, if they don't collect all the other characteristics that cause factors that are related to cancer, it's very difficult to tease out the association just for air pollution. So that's another challenge. Our exposures are much higher. And then we have women who are never smokers. If you look at these maps of nitrogen dioxide, changes in sulfur dioxide levels, global PM 2.5, we know that in these parts of the world, we have levels that are so much higher. And yet the majority of the evidence is coming really from places that are a fraction of what we're experiencing. And that's not to mention household air pollution, where again, they've been defined as group 1 carcinogens. And we do know that the sort of review analyses do show that they are related to lung cancer and nasopharyngeal cancer. So I think that, looking ahead, what do we need to do? We definitely need a better understanding of how air pollution is associated with different types of cancer in these settings at these levels. The challenge is getting the good data to do it. We're on our way, but more needs to be done. A lot of the data comes from China, actually. So they're doing a lot in this area. And then what are these exposure response curves? Because we just don't know, what is happening. This is an exposure response curve in terms of what is the predicted relative increase for lung cancer at higher and higher levels of PM 2.5. And a lot of that data it's modeled, and it's really comes from indoor air pollution exposures. But nobody's really looked at cancer in these types of settings with indoor air pollution. They've looked at other kinds of health outcomes because it just takes too long and you need such huge numbers to do it. But we need more of this work.
Sorry, just go back to the previous.
Oh, yeah.
So is the green dots are measured data, is that right? And the red is model?
Well, no, these are estimates based on, yeah, go ahead.
So the green circles at the bottom, those are studies that have measured some increase in relative risk for ambient air pollution. The green triangle is household air pollution, and then that's all passive and active smoking. So it's the continuum of exposures that's used to develop this.
Well, that's basically it. Just sort of food for thought and thinking about how to make sense of what we already know and steps for thinking ahead.